Hi, it's Dr. Centeno, and welcome back to You've Got the Power. I'm still getting over a little cold, which didn't help this weekend. I flew down to Florida for a conference and to see my mom. So still got a little bit of it. So I just want to make sure you know that. And today we're going to talk about an interesting topic, which has to do with craniocervical instability patients or CCI patients that come in with facial pain or trigeminal neuralgia, as many of them get that diagnosis. And the question is, can that be tied to what we're seeing with CCI or craniocervical instability on the imaging? Now, some of this is going to be due to irritation of the trigeminal nerve branches as they come out of the skull because of the extra skull to neck movement. But I'm going to go over a short presentation today that also shows that some of it could be due to irritation of the sides of the spinal cord. So let me go ahead and share my screen. And start that presentation. So the title of today's discussion is, can C1 C2 Overhang explain trigeminal neuralgia symptoms in CCI patients? Now, again, as usual, I'm going to go through this. I'll probably spend about 10 minutes doing that, and then you can go ahead and ask questions either about this topic or anything you want to ask about. It doesn't have to be about this at all. I'm happy to answer anything. And the reason why I do these once or twice a week shows is to try to make sure that patients get their questions answered. I answer a lot of patient questions. My staff answers a lot of patient questions, but I find that there's still questions that have to be answered. So this is to try to reach out to patients and answer their questions. So one of the key concepts here that we'll be talking about is this idea of C1 C2 overhang. And we see this usually on a digital motion X-ray or what's called a DMX. And that's a real-time X-ray where during an open mouth view, the patient tilts their head right and left. So what we're generally seeing is this view down here. And C1 and C2 are supposed to stay nicely lined up as you tilt your head over. And there are maximum allowed movements here based on the Freeman and Katz study. And if we see more than 2 to 3 millimeters of overhang, which is over here, of C1 shifting relative to C2, then that's called C1 C2 overhang or abnormal C1 C2 overhang. And that indicates atlanoaxial instability, usually relative to the alar ligaments, the alar ligaments that normally would go up this way. So that's what we're talking about today. Now, if we look at that and we superimpose on the same images that you just saw, where the spinal cord would be, which is just behind that dens, which is this yellow box right here, this one, what we tend to see is that if you have overhang, eventually that lateral wall of C1 is going to bang into the spinal cord because the spinal cord isn't necessarily moving a lot there. So that's the general idea of what we're discussing today. What would happen if you had a lot of overhang and you were banging into the side of the spinal cord or even lower brainstem? Well, what would happen is this, and this is sort of really interesting to take a look at. This is the trigeminal nucleus. So what happens here is you've got all of these trigeminal branches which come in and then they will descend, and where they collect is called the trigeminal nucleus. And as you can see, it lives right on the side here of this area, which is going to be the lower part of the brainstem and the upper part of the spinal cord. Same thing down here. So if we have C1 banging into this area, it's possible to get activation of those trigeminal nerves, because that's what those nerves are synapsing, meaning that's what those nerves are connecting to, and then they go up into the brain. So interesting concept there, that if we bang into the side of this lower part of the trigeminal nucleus, we could get facial symptoms like trigeminal neuralgia. Now, how much room does someone have in there? Now, this is just a random MRI from one of my patients. Obviously, I'm not going to show the name here, but I wanted to see how much room is in there in sort of the average John Q patient. Obviously, this would be more or less depending on a different patient, but we've got about 5 millimeters on this side, and this particular patient has about 6.5 millimeters on that side. So that's how much room is between the spinal cord and the lateral atlas there. So not a lot. So that would mean in this patient, if they had 5 to 6 millimeters of overhang, it's certainly possible to bang into the sides of that spinal cord and upper brainstem. And that's where these trigeminal nuclei would be located, or at least their terminus, the bottom part of those. So that would explain the connection pretty nicely. Now, that doesn't take into account that some of those, trigeminal nerves are coming out at different places around the brainstem, and that might be a separate mechanism. But this is just one focusing on this C1 area and atlantoaxial instability. So here we've got a patient who has 7 millimeters of motion. So again, very possible that the spinal cord is getting banged into over here, and that is causing this trigeminal pain. So just an interesting thing, food for thought. It does sort of connect together what we see in overhang and in some of our patients. Now, not all CCI patients have trigeminal neuralgia type symptoms. It's just some of them that do. But I thought this was an interesting discussion to have. So let me stop that, and I will go and take your questions. Again, your questions don't have to be about that. They can be about just anything at all. So let me stop the share here. Let's see. Regenexx, Symptom Advanced by Harry Winston. How common is TMJ in CCI patients? That's because I have 3 other people I know personally with CCI, 2 have TMJ. It's very common. We see it a lot. And I think, as I've talked about before, what generally happens there is that the strap muscles up front, and especially those involved in chewing and mastication, get overloaded and start to be used by the body as head and neck stabilizers, because the normal deep stabilizers are offline. So we then end up seeing this overload of the TMJ, and eventually the TMJs can wear out. So it's pretty darn common. Submitted Advance by Jean LaRoche. If a patient has both of these issues, can they be treated together? I'm not sure which two. I think you mean trigeminal neuralgia and CCI, based on what I just discussed. So the answer is yes, although our usual focus is trying to treat the CCI and seeing if the trigeminal neuralgia symptoms go away, which happens a lot. So, but if we need to treat it separately, it can be treated separately. Hi, Dr. C, great topic. Pain is my main symptom. I had 1 round of PRP and 1 PICL. I see improvement on energy and do not feel as sick as before, but I still have pain. Back of my head and neck hurt very much as the pain lessens and improves with PICL. Yeah, Manuela, a lot will depend on what's going on there. So one of the things that we see is you've had a long time or a long amount of time with instability, that can then fry certain structures, right? It can cause injury to the nerves. It can cause injury to the joints. So it may need to be that those joints need to get treated, or those nerves need to get treated separately. So there's two concepts here. One would be go for the second PICL and see if the pain resolves, and or get a little bit more aggressive on treating some of those accessory structures that can cause pain in the second procedure. And so those are things to talk to your doctor about. Even Centeno, what doctors perform PRP and PICL can you recommend in Europe? Having facet arthritis so severe that it can barely walk, spinal instability, and possibly EDS. I've heard Dr. Janusis, who was in Belgium, is now in Switzerland, and also Dr. Glowacki in Poland. Regenexx is too far. Fortunately, it's hard for me to get there. We don't have any physicians right now who I'd recommend in Europe who are doing PICL. It's too complex. There's too many moving parts right now for any other clinic to take it on. So that's not going to work for sure. I thought that Dr. Janusis is now at a clinic where he cannot do that kind of work. So I think that crosses him off the list as far as PRP. And then I don't know Dr. Glowacki in Poland at all, so I have no sense of who that is. So regrettably, all we have is the London clinic right now to do posterior upper cervical PRP and posterior injections. They do a good job of that. In fact, I just talked to Dr. Zebig over the weekend at a conference in Florida. He was at a conference in Florida. So I think we're very well aligned with that clinic. I'm sorry it's a little bit too far away, but obviously closer than here. They can't do PICL, but they certainly can do the posterior PRP. Todd, this is super helpful. Thanks. I had trigeminal neuralgia and it's a living hell. My neurosurgeon saw a trigeminal nerve wrapped by an artery. We have checked a DMX to see if it was a contributing factor. I suspect I had such a bad artery plus nerve interference that the issue wasn't CCI. Yeah, Todd, may not have been. Just talking about one mechanism that can tie those two things together here, but your case may not have been due to that. My injury is 10 months old, but my overhang is large, 7 to 8 millimeters. Yeah, so Manuela, because of that, probably looking at a second treatment because of the amount of overhang. Now, something we can easily do is to check a second DMX and just that portion of the DMX to make sure we're heading in the right direction with you, because we should see some decrease in the DMX after the first treatment. Christopher, what ligaments do you focus on when you administer DDD treatment? Do you get enough PRP at once to treat multiple levels? Chris, there's really no reason to be concerned about treating multiple levels. The nice thing is obviously up to the amount of blood you have in your system and your overall size, usually getting enough blood to do PRP type treatments is not an issue. That would be very rare if it is. And the ligaments that we focus on would be the supraspinous, interspinous ligaments, usually in the back, iliolumbar ligaments, sometimes intertransverse ligaments. So those are the primary ligaments we focus on. It's also possible to focus on others as well. Hi, Nicole. Hi, Dr. Centeno. What would be the second more aggressive treatment for the nerves affected in the back of the head? That could be, for instance, going after the third occipital nerve here in the midline, could be going after the greater occipital nerve, lesser occipital nerve, all of the occipital nerves as they lay just above a certain tissue plane, or even the third occipital nerve on the side of the C2-3 joint. So lots of different possibilities there for areas that might need to be treated. Nicole, in relation to Manuela's question, I'm going to get once in the back of my head, hurts so much still. Yeah, so Nicole, I think you just need to talk to your doctor about what the issues are there, and then you need to make obviously an informed decision on whether you want to get more aggressive for number 2. If you've got a lot of overhang like Manuela, you may want to confirm that the first one reduced overhang, and it just may not be in that movement amount where things are not getting irritated. But that's generally how that goes. How do you feel about the Mexican allogeneic umbilical cord cell therapy industry? Could this be an option for some people? No, Chris, there's no one in Mexico who would have anywhere near the sophistication to put these cells where they need to go. That just doesn't exist in Mexico. And we're not talking magic here. You can't inject cells IV and have them magically go into ligaments in the upper neck or joints in the upper neck. So they've got to be placed exactly where they need to be, and there's no one in Mexico who has that skill set. In fact, we struggle to find people in Europe who have that skill set, where the quality of medical care is much, much higher than it is in Mexico. So no one in Mexico is going to come close to that. Trigeminal neuralgia is often caused by nerves by conflict with something rubbing them raw. Is there regenerative treatment that can regrow the myelin sheath and has need for brain surgery? I don't agree with that concept of trigeminal neuralgia. I think that's how the surgeons sell their treatments. I also don't believe that is generally what's happening there for the most part. So really, I don't think you need to regrow a myelin sheath, because I don't think these nerves are getting rubbed raw. I do think that what's happening is you could get compression of the the veins and arteries that supply the nerve. I think you can also get constricture around the nerve from swelling and from scarring. But as far as nerves being destroyed, as you're describing, I don't think that happens. I think that's a surgical sales technique. Mexico, what about easy joints, large synovial joints? Chris, I can only tell you what I've seen. What I've seen is a lot of blind injections that are below the U.S. standard of care. That means that you stick the needle somewhere in the vicinity of the joint, and if it gets there, it gets there, but you've got no idea. So I've not seen good things thus far from any what I would call Banana Republic clinics in Mexico or those in Panama. The biggest problem that they have down there is that, unlike something like Cayman Islands or the Caribbean, where U.S. doctors can get licensed in those Caribbean islands because they're desperate for doctors, right? They don't have large medical schools themselves. That can't happen in Banana Republic clinic or countries like Mexico or Costa Rica or Panama. U.S. doctors can't get licensed down there. The local doctors won't allow it. So that's their biggest problem. So if you open a clinic down there, you've got to have U.S. doctors that are doing this work, because the standard of care down there is going to be dramatically lower than it is here in the U.S. And it's going to be very, very hard to find physicians who are practicing at that much higher level in those countries. So if you've got a country where a U.S. doctor can get licensed, who's gone through U.S. training, then that may be a different story, and who practices here in the United States and then maybe goes down there to do some patients. In addition, the practice environment is totally different. Here in the U.S., we're constantly minding our P's and Q's because there's the concept of medical malpractice here, which is quite real. Again, in those countries, not so much. So it's a completely different world. Nicole, can CCI cause visual changes that specifically involve feeling like my eyes are crossing? Sometimes visual changes result in migraines and feeling of panic. Yeah, Nicole, that's pretty common. So if you read the book, and let's see if I can find that link for you. Let me see if, hold on a second. Let me see if I can find the book link so you guys can download that, and I'll put it in the comments here. But if you read the book, it goes into that in some detail. And the reason is that there are reflexes that go back and forth between your eyes, your inner ear, and your upper neck. And all of those have to coordinate. And what's happening in your upper neck and eyes is coordinated as well. So when the upper neck is giving bad information to the brain about where the head and neck is located in a given moment relative to where the eyes are, you're going to get problems with your eyes. And in fact, you can measure that in what's called a smooth pursuit neck torsion test. So I'm going to put the link to the book. I'm going to call it CCI book in the comments so that you guys can have a link where you can download that. And that really goes into all that kind of stuff. Sian, I just got my imaging on my MRI flexion extension and no more MRI of cervical, lots of images on there. Can I send that for you to read, please? Yes, Sian, if you want to do an online consult because you're planning on coming to treat with me, that I'd be happy to look at that. Obviously, if you're in Europe and you're thinking of seeing the guys in London, then I'd send that to those guys and have them take a look at that. But happy to take a look if you think you might come here for treatment. Liam, if the CCI was caused by an acute immune reaction, once that reaction is done, can the patient be viewed as physical injury CCI patient? Yeah, Liam, I don't know of an immune reaction that causes CCI at this point. I'm not saying that can't occur. I'm just saying I don't know of a mechanism for it to occur. So until someone explains that to me in some way that's credible from a medical standpoint, that's a really hard one for me to conceptualize at the moment. So that's something, I'm happy to take a look at what's ever out there on the concept of ligament injury and immune reaction. But I don't think we know enough yet in that world to tie those two things together very easily. Zach, I actually have had big improvements in pain and stability with my PICLs, but many neurologic symptoms still. Symptoms are worse when I lay on my side, flat on back, or lean forward. And when I turn my head to the side, perhaps head is shifting horizontally. What ligaments are those? And PICL treat, and those are surgical options best. So let's see. You're saying here, symptoms are worse when you lie on your sides. That's going to be more alar. Flat on your back or lean forward, that's going to be more transverse. Turn your head to the side, that could be more alar. And shifting horizontally, that's going to be more alar. So those are ligaments that PICL could treat. What I'd probably recommend, Zach, is that we look at a repeat open mouth DMX and just do that part of it, just to see where you are in reducing that abnormal motion and getting it closer to normal. Tyson, can any Regenexx provider provide intradiscal injections? The answer is not any provider, but I would say probably these days about 2/3 of our providers offer intradiscal injections. So you're going to want to make sure that of that site. So the first thing you would do is to go online and look at what areas they state they treat. If they're treating spine, reach out to the clinic and make sure that they do intradiscal injections. What about allogeneic stem cells in and of themselves, if deploying them properly was not an issue? Yeah, the big problem, Chris, with all allogeneic cells, and it's not just umbilical stem cells or umbilical cord derived stem cells, is that they've got to be HLA matched to the person. There's some very convincing data that's come out in the last several years that we believed that these things before didn't need to be HLA matched to the person. Not so simple. In fact, some of the data produced by Ashley Watson at Texas A&M now shows that we probably need to be actually matching these. And in fact, the first treatment doesn't, the first treatment just doesn't work if they're not properly matched. And then the second treatment is even worse because there's a bigger immune response because they're not properly HLA matched. So regrettably, while the cell therapy industry focusing on creating allogeneic drugs doesn't want to hear this, there's some pretty good evidence coming out that we're probably going to need to find a universal donor cell. And that work's not been done in Mexico at all. So I wouldn't send a family member down there right now to get umbilical cord stem cells for any condition, simply because of that matching issue. So I just don't think it's a good play at the moment. Now, we may find out in time that that we have a universal donor cell, or one that's least rejected, or maybe a mix of cells that come from many donors that cover all the major HLA bases. And that may dramatically improve outcome. But I think a lot of the failures that we're seeing in allogeneic cell trials right now that are going for FDA approval are related to that rejection issue. And it's not usually rejection enough, unless you get the crazy stuff they're offering here in the US, to cause a graft versus host disease, although I've seen that happen here in the US, but it is enough to make the therapy hit or miss effective. Anya, thank you for the answer. I wanted to ask, if I have facet arthritis and instability in all spinal regions, can I have PRP injections in all facets of the spine at once over the course of several days? Anya, we usually only treat symptomatic facet joints. So that would be determined on exam, meaning a hands-on exam over each joint. You can palpate those joints. And so definitely, if they were all symptomatic, then it's certainly possible to treat all, for instance, in the neck, for example, at once. And we've done that. It's just a lot of injections. Studies referring to our animal studies, there are human studies with allogeneic bone marrow donors that show that HLA mentioned. Yeah, you're not reading the same literature here, Chris. I'm not sure if you're out there hawking some clinic, or if you're a paid person trying to get people to Mexican umbilical cord stem cell clinics. But like I said, I wouldn't send a loved one down there right now for any possible disease state. So I'm just telling you what I have seen clinically, what I have read in the peer-reviewed literature, which I think I know a bit better than you do at this juncture, and my overall assessment that I wouldn't go down to a Mexican, quote, stem cell clinic right now or send a loved one there. Caden, I get the most aggravation of my symptoms in a seated position. Would the picl procedure possibly be able to help that? My DMX shows an overhang bilaterally at C1 C2. Yeah, so Caden, a lot of that would be if you're talking about seated looking down. But bottom line is, I mean, I have to look at your individual case to see whether or not PICL procedure could help you personally. But some of our PICL patients get worse when sitting down. Usually it's sitting down and looking at a computer screen or their phone or something like that, or a document. And that's something that can be generally treated, but I don't know your specific situation. Yeah, Chris, like I said, I gave you my opinion there. I'm not sending any patients down there for a reason. And that's just not happening right now. I don't think that what's occurring down there is fully baked, both on the physician training side and on what it is they're injecting, and some of the newer research showing an immune response to the cells. In addition, I have to tell you that there's a number of physicians here in the US that used umbilical cord, quote, stem cells, meaning there were no stem cells in it, and defrauded patients who are now getting sued by those patients. And I am a medical expert that's been retained in a lot of those cases because of my knowledge of the literature. And in a number of those, there's been a graft versus host disease type presentation. And we've seen people end up in US ICUs, ERs, et cetera, with very, very severe graft versus host disease responses. So best I can tell you is my direct experience. Ravati, do you test for occipital neuralgia at your clinic and treat the same? We do, but then you've got to go one further than that, Ravati. And what I mean by going one further than that is one thing is just performing a simple physical exam to see if the occipital nerves, if you press on them, can cause headache. The other is why they are causing headache. And that's the question you really need to be asking, meaning occipital nerves just don't randomly start headaches. There's a reason why. And usually it's because of chronic muscle tightness around the nerves. in addition, and that's usually caused in this patient population that we're discussing today by instability. So it's the instability that's the root cause. And obviously you've got to treat the instability. And then sometimes you may also need to treat the nerve. But yes, all that can be done. Do you see a relationship between CCI and shingles? Not so commonly, but I think the thing with shingles has always been that sick nerves get sicker. And what I mean by that is that shingles is an opportunistic infection of the nerve, right? And we all would know at face value that there are people out there who are very unhealthy, and they're more likely to end up in the ICU than someone who's perfectly healthy. I think we'd all have that direct experience. In the same way, a sick nerve can get sicker. So if you've got a nerve that has a lot of problems because it's getting beaten up all the time from the CCI, it's going to be more likely to get sick with something like herpes zoster virus. So just realize that it just relates to the health of the nerve and also the health of the immune response fighting off what's going on. Anya, unfortunately, yes, I have pain in most facets. Is PR done in thoracic and lumbar regions? No, Anya, it can be done in all those areas, but again, only if an exam indicates that that's what should be done. And that's not the quick 3-minute, touch type exam that you get at a family doctor's office, an orthopedic surgeon's office. That's an in-depth exam pressing on each and every one of those facet joints. So that alone for the entire lumbar column is going to take 10, 15 minutes, not to mention all the other types of things that would need to be done on a physical exam. Yamas, AO helped a lot with neurologic pain. Sure, I've seen that many, many times. Era, is there any way to verify neck muscle atrophy? I'm suspecting my inner neck muscles are atrophying, causing my CCI. There's certainly a way to see that on MRI. Yes, you can see neck muscle atrophy on an MRI. That's easy to do. In fact, you may want to look up some research by Elliott, E-L-L-I-O-T-T, Jim. In fact, let's see if I can pull it up now. This is a great story. Jim would probably be embarrassed if I told you this story, but I'm going to tell it to you anyway. Jim Elliott was our physical therapist way back in the day. Let's see. I probably need to do that for cervical. Okay, let me share that. So these are some studies by Jim Elliott, who's now at Northwestern in Chicago. Jim has looked at this issue of neck muscle atrophy and traumatic neck pain quite extensively through a number of different studies. He's done an amazing job of really drilling down on this. And this was all based on a comment one day when he was still working for us, when we were looking at low back multifidus atrophy, which was well known at that time, or starting to become known at that time. And then we saw the same thing in the neck. And Jim really took that and has made an amazing academic career out of looking at all this stuff and identifying that, yes, there is upper cervical muscular atrophy that can be identified on an MRI. So this is the guy, Jim Elliott, or Elliott, E-L-L-I-O-T-T-J-M. And if you just type in that under PubMed, atrophy cervical, you can get all of that information. He's got more too, but I just kind of focused it there. Mark, my ability to hold my atlas correction has improved, but I frequently lose my atlas jumps from chewing. Some folks are almost certain to knock my atlas out of adjustment as well as cause face pain, trigeminal neuralgia type pain. I know my injuries have caused me to grind my teeth down, and I think this may be a big part of the issue. I need to get a DMX in my cervical spine in the process of scheduling that. the DMX be able to figure out exactly what's going on. Yeah, so a DMX can usually get to the diagnosis, but not always. I mean, sometimes we'll need other types of imaging. So I think it's a great next step given what you're discussing. Yes, Era, it's Jim Elliott. He's right up here. So I'm trying to leave that up there so you can copy down his name. Yamas, do you guys have latest videos on injecting transverse and alar? Not sure what you mean by that one, latest videos. So maybe tell me a little bit more what you're looking for. Era, it's looking like I have a neuro disorder that actually in turn has caused my CCI, so I'm a bit of a loss where to go from here. If stem cells be up here, and say if you have neck muscle dysfunction because what's left to keep stable during the months recovering from stem cells. Era, I'm not clear what a neuro disorder is, meaning that covers about 100 different diagnoses. So maybe if you could be more specific than that, that would be very helpful. Yamas, there's a thing called TEC scan that measures your bite, get rid of TMJ. Is anyone looking for that info? Thank you, Yamas. Okay, any other questions I can answer out there? Happy to answer them. Okay, so what we were talking about today was the idea that because of the location of the trigeminal nucleus, or the area where the trigeminal nerve comes to connect into the fibers that run up and down in the upper cervical spinal cord and brainstem, that some patients may be getting trigeminal neuralgia symptoms, likely because the outside parts of the spinal cord are getting banged into because of C1 C2 overhang. There's a few more questions here. Neuro disorder. I've been diagnosed with FND causing the Era. I don't recognize FND as a diagnosis. That's a functional medicine diagnosis, but not a medical one. So I don't recognize that diagnosis. I'm not quite sure what to tell you there. And what I mean by don't recognize is it's a big black box in which functional medicine doctors throw a patient category into, rather than a specific diagnosis that would yield, here's exactly what's wrong and here's what we need to do about it. Tyson, can you recommend Dr. Urbanek in Des Moines Clinic? I saw you back in 2018, want to get doctors closer. Yeah, Tyson, tell me what kind of problem you have, and I can let you know. Chris Urbanek went through our fellowship, so I think he's an excellent doctor. I just need to know what kind of problem you have so I can see if that's a good fit for there. Doug, my BMC appointment treatment for tomorrow was canceled and finally because I was scheduled for multiple joints and needed review by Dr. C before being approved. I don't know what you're talking about there, Doug. So I'm not quite sure what happened there. I'll certainly go ahead and put my email that goes to my desk down here in the comments. And if you can reach out to me so I can see and investigate what you're talking about, because I've heard nothing about that and don't even have a box to put that in right now. So I'm going to go ahead and put in the comments. That's my email address that goes to my desk. So send me an email about that and I will look into that for you. Yamas, measuring the problems with symptoms is vague because everyone's different. I agree. Nicole, is there any ideal time to do PT after PICL? I'm very afraid of ourselves because PT has traditionally made things worse. Yes, do not do any kind of formal exercise program until you get approval from your specific doctor that's treating you, because that can be a very dicey thing. I would agree with you after this procedure. Tyson, yeah, absolutely. Tyson. Chris Urbanek would be great. Again, he spent a year at our clinic doing a formal fellowship, so he has very great training, and I think he would do very well with that. Sian, is there a link between thoracic outlet syndrome and CCI? Yes, there is, because remember, thoracic outlet syndrome, and I'll see if I can put it up here. Let's see if we can find some nice pictures here that will give us an idea of what we're talking about here. Let's pull up some ones focused on scalenes. So the scalene muscles, this might be better. So the scalene muscles serve as the wall, if you will, or the walls of the thoracic outlet. So the floor would be this first rib here, and the walls of the house, if you will, where the nerves come through, are those scalene muscles. The scalene muscles also supply stability to the head and neck. So if you've got upper cervical instability, your scalenes are going to be in overdrive. Hence, the nerves that go down to the arm are going to get pressed on, i.e. thoracic outlet syndrome. So the two are definitely connected. We see that all the time. And as far as tears in the neck, I'm not quite sure what you mean there. So maybe clarify that one a little better. With Asheville Regen Clinic. Yeah, I don't know who that is. Maybe you can, I'll type that in. I don't think I'm going to get anything, but yeah, so you may want to go ahead and tell me who you're talking about there in Asheville, North Carolina specifically, and I'll take a look into that. But again, that's not a diagnosis. So regrettably, we're not going to get real far with that one. I have been diagnosed by 2 MD neurologists with FND. Again, it's a black box, so I'm not quite sure how that gets us any closer to helping you. It's a little bit like saying myofascial pain, where, or saying fibromyalgia. Great, but how does that get me to helping that patient? Or saying central sensitization. These are all boxes in which to put patients that get us no closer to helping that person. Tyson, I had an L4 and L5 disc tears with the treatment I got from you. L4 healed, but L5 did not. Yeah, Tyson, so if you need more treatment, I think for that, Chris Urbanik would be a great choice. Aaron, I'm not sure what that one means. Yeah, again, Era, a black box in medicine is is very common because it's easy for doctors to use that black box, but it doesn't help us get to what's going on. So let me give you a great example. I can say someone has fibromyalgia because I press on a lot of parts of their body and they hurt all over the place. But in my experience, 90% of those patients have very specific, quantifiable, diagnosable musculoskeletal diagnoses. If the doctor was more knowledgeable about how to make those diagnoses, that can lead to specific treatments. And those specific treatments can then lead to a marked improvement in that patient. Now, that same patient was thrown into the black box called fibromyalgia, for which there is no cure. All ye who pass through here abandon hope kind of thing. But they never really had fibromyalgia. They met that definition of the black box, but there was something specifically causing those problems, and no one really took the time to figure it out. In fact, if anything, in our medical care system, it was disincentivized, right? The more time I spend with a patient, the less money I make as a doctor if I've got an insurance practice. The more patients I run through my practice, the more money I make. So regrettably, that's the problem that we find ourselves in our current medical scenario. So black boxes are extremely common, right? I want a box I can go ahead and throw this patient in so I can get to the next patient. But that box isn't going to help me help that person. Sure, Tyson, happy to help. Again, the reason for doing this program is I find that even though I spend a lot of time with my patients in the office, for instance, my initial evaluations are generally an hour long. Now, some of that will be spent with Carla getting a history, but most of that's spent with me one-on-one. So I spend a lot of time answering patient questions. I still find that there's patient questions out there that go unanswered. And regrettably, unanswered patient questions are the cause of a lot of anxiety for patients, and also cause a lot of problems in the medical care system because people just don't get that connection they need to get their questions answered. So that's why you'll see I try to, God, I'm probably down to only 3 or 4 blogs a week, but I used to do as many as 5 or 6. And I've posted 3,000 blogs, and I've written 6 or 7 books. All of those are trying to get patients to understand what's going on, because I always find that when a patient understands what's wrong with them, they become a partner in trying to get that person better. And that's an amazing thing if you're a doctor, right? You have someone who's helping you give insight about what's happening in their body, which you try your best to understand. You do an exam, you take pictures, but only they're in their own body. And so if you can make a patient into a partner in helping them get them better, that's an amazing gift as a doctor, and obviously to the patient as well. HRH, what about neurologic symptoms, i.e. nystagmus? Yeah, so nystagmus is another one that goes hand in hand with what we were discussing. So that goes down to something called smooth pursuit. Oh, sorry about that. I'm a doctor. I got to check that. Okay, so smooth pursuit. Let's see if we can see something that would give you a sense of what that is. Here's actually the one I was talking about, smooth pursuit neck torsion test. So smooth pursuit is where you're actually tracking an object across your visual field. Now think about where that came from, right? Where that came from is, from an evolutionary standpoint, is when we used to hunt with, let's say, throwing a spear. That's an amazing feat of accuracy, right? You have to determine how far away that animal is. You've got to figure out how fast that animal is moving across your visual field. You've again then got to adjust all those variables and somehow throw the spear so that when it gets to the animal, which takes a little bit of time, it gets to the right spot. And so smooth pursuit is a critical thing that used to be involved in keeping us alive on a day-to-day basis. And when you're doing all that, you're turning your head to keep the animal in your visual field, to keep the smooth pursuit accurate. So it makes sense that there's a connection between smooth pursuit and the upper neck, and that those two systems talk to each other. Now, when you get bad information from the upper neck, that's going to cause the smooth pursuit to get ratty or nystagmus. And that's when the eye jumps in the middle when you're trying to do a smooth pursuit. So nystagmus is the same thing as we were talking about before. It's these connections between your upper neck and your eyes, and that they have to be timed perfectly with micromillimeter, microsecond precision to work accurately. And when the information from the upper neck is bad, then that system can't work well. Yeah, Chris, we're just kind of getting into a back and forth here that's not really real productive. Listen, I've been training physicians in interventional orthobiologics now for almost 2 decades. And I can tell you that you've got to have a bunch of things under your belt first. One is you need to understand how to examine the musculoskeletal system And whatever it is you learned has got to be supplemented in a big way in order for you to be able to choose the right treatments for the right patients. I can tell you that you've got to have image guidance skills when you walk in to a class, and then we've got to expand those dramatically over what it is you have. And none of that is easy. I'll tell you the story. Here's a not a nice story, but a story that's real. And that was, we had an orthopedic surgeon come in from India one time for one of our Interventional Orthobiologics Foundation courses. And that was early on when I was still involved in the day-to-day training of that organization. And this guy was a nightmare. He had no sense of how to guide a needle under X-ray guidance or ultrasound. And, thankfully it was not a live class and on a real patient, it was on cadavers, but he was destroying the cadavers even in trying to do these procedures that he just wasn't qualified to do. He never had done that before as an orthopedic surgeon. And so I took the unusual step of failing him for the class, but that didn't really make a difference. He went right back home and did a bone marrow aspirate procedure. And then about 3-4 weeks later, I get this frantic email, obviously on his time. So it must have come in at 2 a.m. or something, but I wake up early. So it's 5 a.m. I check my email, and there's this frantic email asking if a retroperitoneal hematoma is a common complication of a bone marrow aspiration. The answer is it's not. So what he had done was to take the trocar, and because of his lack of experience, despite being failed, and he put it through and through into that person's abdomen and almost killed that lady. So he was trying to defend himself from a possible malpractice suit in India. So that's a great example of the qualifications you need to do this stuff. And it's a scary example, right? Do you really know that your doctor isn't that Yahoo? You don't. And so that's why we developed Regenexx, because we qualify all those doctors. They've got to have specific training to walk through the door. They've got to go through specific coursework through IOF, specific coursework through Regenexx. And then they got to get my seal of approval to even be invited to be on that network. And if I detect that there's any problems, they're kicked out as rapidly as they were brought in. So there's no one else out there doing that. There's no one else out there who's doing anything like that. So I can definitely hang my hat on those statements. CN, small issues, the average human seem to be drastic with someone who has instability issues. Do you notice this? Infection seems to last twice as long. Yeah, I think one of the things you're seeing there, and this is an important concept, right? Because, for example, there's a study that shows that if you take a patient with relatively low systemic inflammation, meaning in the whole body, and you look at how long it takes to heal after an acute low back disc herniation, it's pretty quick. Within weeks, they're up and about doing what they want to do, usually with very little treatment. But you take the same age patient who's got a systemic inflammatory problem, meaning inflammation levels are high, and it takes 6 months to a year to recover. So I think what you may be seeing is some of that effect. And it's an important thing to consider. So something you may want to get checked on is what's called an HSCRP, high sensitivity C-reactive protein, just a serum test or other tests to look for pro-inflammatory blood markers, because that's something that could be happening that explains what you're experiencing. Peter, hey, Dr. Centeno, hope you're well. Thank you for all these live streams. I read something recently. There's potential migration of benefits of orthobiologic injections, such as, let's say you inject only one area, but the surrounding areas can benefit not just from added stability or healing in that one area, but from actual physiologic migration of the growth and healing factors. Does it seem true or not likely? Yeah, Peter, I think to a little bit of an extent that might be the case, but a lot would depend on what we're talking about. So for instance, if you put something into a knee joint, then it would be contained within the entire knee joint. So those growth factors are going to migrate throughout that joint. But if we put something into a very specific ligament, then 90% of that stuff is going to stay inside that ligament. Now, you may get some migration through the ligament. You may even get a little bit of out migration but not a lot. And we can tell that because we'll put contrast in these ligaments. And then, many times we have to stop the procedure for something. And then we'll come back and re-x-ray that part and to do another injection. And we can see how long that contrast stays there within that ligament. And it generally stays within that ligament. And eventually the body will wash it out, but through small blood vessels that are within the ligament. Or if it's in a part of the ligament with very poor vasculature, it'll stay much longer. So I think really not as much as big a deal. Now, one of the things we do know, because they tested this for WADA, or the World Anti-Doping Agency, is that if you give PRP, you can see small blips in growth factors in the body. They're small, but they're detectable. So, and I've actually had a couple of PRP shots where I felt that effect myself. It's not a lot, it's just a little bit. So that's something that can happen, but I think it tends to happen more when you put that stuff in an area that's well vascularized. Thank you. Yeah, I only been to Germany once. Great country, but no plans of moving there anytime soon. HRH, thank you for your answers. Does also apply to GI issues, feeling faint. There I think you're talking about irritation of the vagus nerve, and I think we've, let's see here. I'll see if I can pull that up here. There's a blog about internal jugular vein or vagus here. So if you go to the Regenexx site and type in vagus, this blog here talks about the location of the vagus nerve versus the transverse process of the atlas. So that irritation of the vagus nerve can cause all sorts of problems, including feeling faint or POTS-like symptoms, and GI issues, because the vagus nerve controls both how fast the heart beats in response to things, as well as the GI system. Connor, does higher dissection, let's bring those pictures up there. Does higher dissection help trapped ulnar nerves? I have carpal tunnel, ulnar nerve entrapment with EDS and very lax wrists. Yeah, Connor, that's possible for sure. I think the first thing we would do with an EDS patient is to get the joint stable through injection, whether that be prolotherapy, PRP, bone marrow, depending on the person. And once we get it stable, see if the nerve gets better, because frequently the unstable joint will bang against the nerve. Then if it doesn't, that can be treated separately with higher dissection using a platelet lysate. And if we look at that, there's a whole page on the Regenexx site about carpal tunnel treatment. Same thing would apply to ulnar mononeuropathy or entrapment at the elbow. If someone doesn't respond to PRP nor prolotherapy, could there be a problem at play? Yeah, if you're an EDS patient in particular, I've seen that certain EDS patients tend to under-respond to PRP treatment of ligaments. They'll frequently respond to prolotherapy treatments, but not always. And some of those patients need bone marrow concentrate to really get a robust effect. Realize that EDS isn't one disease, but it's a spectrum of problems that are genetic related to stretchy collagen. So it could be one of several different collagen defects. And not all of those are going to respond the same way to orthobiologics. Now, hopefully sometime in the next 10 years, long since I've sailed away into the sunset, somebody will figure all that out on a genetic level. But right now we don't have that. Caden, I don't know the device yet. So, oh yeah, here it is down here. I've ever heard of a device called posture pump for curve correction. Yeah, Caden, the posture pump is definitely pretty aggressive for curve restoration. So I think it would work better if you were a younger patient. Um, but if you're really concerned about curve, you should see a chiropractor specializing in chiropractic biophysics, or CBP. That would be a good person to see, because that person can then go ahead and try to see which devices are best for you to use at home. The posture pump is pretty aggressive, I would agree. Tyson. Yeah, Tyson, I think that this treatment, and I got to start winding up here because I've got a 2 o'clock meeting and we're at 2 o'clock Mountain, but great to hear that disc bulge is resolved. I think some of those disc bulges will resolve spontaneously. Sometimes they'll resolve because we're stabilizing the functional spinal unit. Really all we're trying to do is to help the body along so it can do what it's supposed to do. Can CCI impact EEG? I don't have a sense of that at this point. Yeah, got that. And Connor, if a patient can do a systemic ligament laxity throughout the entire body. Yeah, so Connor, that reminds me of the last question I can answer because I've got a hard stop at 2. But yeah, so that's a very common problem that we see. And in fact, my first experience of that was my niece. My niece has a rare collagen 10 defect, and she was she was a PhD candidate and now is a PhD, but she went to Oxford. So she was in the UK. They had arranged for her to get a complete genome sequencing. So she did. So they know exactly what's going on with her. And so what we did in her was to start with, she did respond to prolotherapy in lots of different spots. And then once we got certain areas under control, other areas would point themselves out as bigger problems in the kinetic chain. So we went to bone marrow concentrate there and would spot treat with bone marrow concentrate. And then we went through multiple cycles until now she's pregnant, you know. So that's a big deal for her because she didn't think she could become pregnant. I mean, she was literally that kid who, you know, would dislocate her kneecap if the elevator jerked going down, that kind of thing. So that's, we would approach it the same exact way. Okay, guys, thank you so much for watching today. It seems like we had a great crowd on here asking some really, really good questions. And as I said before, watch the beginning of this video, which goes over why that C1 C2 overhang can cause trigeminal neuralgia. So thanks so much for watching, everyone, and have a great day and a great week.